It is the top of the hour, so let's go ahead and get started. I'm working through my video as well. And welcome everyone. We are so excited that you are here and able to join us and spend this time with us. Today we have Dr. Verna Little. She is a psychologist as well as a social worker, and she has been working in the CoCM training for a long time. I'm going to say she's one of the premier national experts and trailblazers in this work. Anytime I'm attending anything or reviewing articles or thinking about the CoCM space, Verna is ever present and answering questions and leading the charge to make sure that CoCM is taught to the fidelity of the model and is well represented and an advocate. So I just want to say Verna is here today to do the second of 3 trainings that we will be doing in order to provide a foundation for the collaborative care model, or CoCM, as part of this grant. And we are so excited that she is here today. Without further ado, I'm going to turn it over to you, Verna. And you can let us know if you want people to ask questions along the way, put them in the chat, what your preference is. We'll have.
Yes, super glad to be here, everyone. And please feel free to do any or all of those. I do watch the chat as I go. If you're feeling shy, send it to me privately. If not, put it out for everyone. Likely you're not the only one to have that question. Or feel free to unmute and literally just stop me along the way and say, hey, stop right there. I have a question, I have a comment. And I'm super glad to do that because, again, you are likely not the only one that's either, confused or has questions or, needs to be able to take a little bit of a deeper dive. What I'm really hoping today is that we can have a pretty in-depth conversation around the billing and the coding and sort of the financing piece of it. So again, you can, go back and have some of those conversations in your organization. I know we have some folks that haven't joined us, and I always like to start and just ground us in what we're talking about and the model. So collaborative care is an evidence-based model to identify and treat patients with depression and anxiety in health settings. And one of the things that we know is that it actually spreads past those diagnoses, right? So that we're now doing a lot of work around bipolar and PTSD and ADHD. Pretty standard now to include kids in collaborative care as we're going along. And there's a national group actually working on a pediatric pathway that we hope to share very, very soon. So collaborative care, the evidence is there. In terms of this works, helps to get people better. It reduces symptoms. It helps individuals with chronic condition. It lowers the cost of care. I know that all of you saw the latest cost report on collaborative care. I think it got shared multiple times. If you don't have it, I'm quite certain several people on this call could have it in your inbox fairly quickly. We also know that this model is sustainable. And everybody oftentimes will say, I don't know if collaborative care is financially feasible. And I'm telling you that in some places it is not, because they're not covered on the Medicaid fee schedule and somebody has a lot of Medicaid patients. Or I got a call the other day from an FQHC in Texas, and 60% of their patients are uninsured. Well, it's hard to make anything self-sustaining when 60% of your patients are uninsured. Like, you're going to get, your 330 money, but like basically it's very hard to be able to make something self-sustainable, but it can actually happen. And then remember, these codes are billed under the primary care provider. And so you want to be able to leverage your current contracts. You don't need to do anything different for behavioral health. And at this point, I'm happy to say 34 states have the Medicaid codes passed as part of their fee schedule, minus yours for Medicaid. But hopefully we're still working on that, Kim. We're always going to be plugging away at that.
Absolutely.
And of course, Medicare Advantage, and the commercial plans, These codes were auto added to your commercial contract. So if you had, yes, thank you, Patty. That is absolutely a good call out. Our friends at the Blue Plan do cover the collaborative care codes across their entire population, and they are leaders. So thank you. That is an absolutely wonderful contribution, and thank you for that call out. So for the commercial plans, they were auto added to all of your contracts. So you don't need to worry about doing anything with your commercial payers. They're already there and auto added to those contracts. So this is a pretty picture of what collaborative care looks like. I just am gonna go through it very quickly so that we're all grounded. I really like to do a refresh every time. We're adding the behavioral health care manager and the psychiatric consultant to the team, to the healthcare team. We're being incredibly interactive and patient-centered. We're using that monthly case rate that we're going to talk a lot about in terms of billing and coding. And we're using a registry to keep track of everybody on your population that needs behavioral health interventions. And I want to just stop for a moment and talk about the treatment choices. And the treatment choices are directly tied to financing. It's really important to know them because you really can't do collaborative care successfully without knowing the treatment choices. However, they're also directly tied to financing. So I was on the phone this morning with a practice in Pennsylvania, and they actually were having a hard time. And it turns out that a lot of their patients, turns out more than 90% of their patients are in talk treatment. And so they're spending a lot of time with patients, an average of, 4 or 5 hours a month with patients. They're having trouble reaching some of the other patients because they don't have time to do the outreach. And so that really is kind of winding them in a bit of a pickle. And so if you really are spread out across the treatment choices, you're not going to have a trouble with sustainability. Generally, we find that the 15 to 20% of patients that are in talk treatment at any given time is kind of a good number, and that's really where it should be. And remember, somebody can be in talk treatment for a week, right? And then not the following week. So people can move in and out of these treatment choices. But having too many people, so I've also talked to practices that kind of put everybody in symptom monitoring. Well, then they have trouble oftentimes being self-sustaining because they're not engaging people. And so then what happens is they're not able to bill for a lot of the patients on their registry because they're not engaged in care and they can't reach them. And so it's really important. These treatment choices, and we'll talk about that more, do actually sort of correspond with some of the activities that you can do. And there's lots of different financial implications for these treatment choices. So generally, if I'm thinking about collaborative care, I'm thinking about one initial foundation code and 2 add-on codes. It's roughly about 2 hours of care a month, and we'll take a deeper dive there. But if I'm spending way more time than that in care, then that becomes uncompensated care. And not engaging patients is probably one of the bigger reasons that people really have trouble being self-sustaining. There's a couple of reasons for that. One is that you're not spending enough time initially with people. So we know that people that have more contacts in the first 1 or 2 weeks of treatment are more likely to engage in care, which means they're more likely to be billable that month. We know that carrying people from month to month on your registry. So I tell people, don't carry people. If I engage Kim in care, and then Kim falls off the planet and I'm not sure where she is, which some people are going to do, right? And I'm not going to carry her for 2 or 3 months on the registry. At the end of the month, I'm going to do some outreach for her, and then I'm going to close her out of my registry so that I don't have a lot of people that are I'm carrying from month to month, which increases the number of people that we're not able to bill for. So that registry efficiency and management and the treatment choices directly tie in to some of the finances. And so when we think about considerations for staffing, A couple of things. CMS does not require licensure, right? Oftentimes people will ask nursing versus behavioral health providers. I love nurses. I just joined a project today in Colorado to train nurses, right? I'm near and dear to me. One of the things, though, is that nurses, particularly RNs, tend to be more expensive or higher salaries than many behavioral health providers. And so if you add that higher salary fringe and overhead, then that's really going to hit your bottom line. So that's an important consideration. Oftentimes practices have other uses for RNs other than doing some of this work. And master's level versus clinical social workers, or in particular, independently licensed versus just master's prepared and not yet licensed. So, individuals do not need to have independent licensure here. And so people who are master's prepared actually do wonderful. So there's a difference. What some organizations do is that I work doing collaborative care until I get my independent licensure, and then maybe I take on another role. Also, people ask me about psychologists versus social workers versus counselors versus marriage and family therapists. The salaries tend to be all about the same for the master's prepared. Psychologists are a little bit of a higher salary, and so that's certainly a consideration. So you do not need a psychologist to do this work. It really depends on what you're looking for and how that's going to impact your budget. But there definitely are monetary or budgetary considerations for who you bring into this role. And also, it is super important to understand what caseload you are sustainable. I can't emphasize this enough. If you don't know this, it is going to be very hard for you to run a collaborative care service line. And what do I mean by this? Most organizations, so I was just on the phone with an organization in Pennsylvania today, and their reimbursement is not stellar. And so we figured out that if we took the salary fringe and overhead for the person they have in the care manager role, and we took the average reimbursement across their payer mix, that they were going to have at least 71 patients in care, billable episodes each month to be self-sustaining. So given that the average caseload is 90, but given that not all of them are going to be billable, they're going to be self-sustaining, but not by a huge margin. And so you should know at what caseload number are you self-sustaining. Generally, it's like 60 to 65 patients. That doesn't mean that's where your caseload stays, because it shouldn't. It should be up, into the, 80 to 90 range, but you need to know that number. Also, when you think about financial considerations for staffing, this is telephonic. It's telephonic work before telephonic work was fashionable. And one thing to really also remind people here, these are not telehealth codes. People often get confused with them as telehealth codes. They are not telehealth codes that sort of fall under the myriad nightmare of regulations and requirements that go along with telehealth that are ever changing and making our lives tough. These are actually a monthly case rate that allows for telephonic services. And so don't get confused there, but that telephonic service then allows us to be in multiple locations. So you can hire one person and you can have them cover multiple locations. You could hire somebody and have them be hybrid. You could hire someone, maybe that's master's prepared, that, is entirely remote. So it gives you the opportunity to have some flexibility there to attract other people into this role, to retain them into this role, because it's certainly costly, when we lose someone, and also the operating efficiency of covering multiple locations. So I had an organization recently and they had several practices, and they didn't have the funds to really start someone with each of the practices. And so they started someone remotely working across, well, actually she was in one practice, but she worked across all of the other locations. And they actually found out that that worked fine, and that two of the practices weren't really had enough volume to support someone. And so it was a really good learning experience. And now they're kind of figuring out what that's going to look like long term. So that is an important piece to think about when you're doing some of this. So I want to stop there for a second and just answer any questions that might be there around staffing in general, because remember, you can always toss out sort of general collaborative care questions. So any questions about the model or any of the financial considerations that we've talked to at this point. And I'm also going to ask if any of you know the number where you're self-sustaining. So Tisha, I imagine you've looked at this for your system, but interested to hear from some of the others what that number looks like if you've done that.
I have a question, and I may be jumping ahead, so if this
No,
is answer
go
later.
for it.
I'm just wondering if you factor in, you mentioned the workload or the caseload as 60 to 65 patients sustainable. I assume that means paying, but do you factor in a number of patients that are maybe you may not get reimbursed for, or how do you factor in that?
Yeah, generally. So I factor in the salary, fringe, and overhead for the care manager and the psychiatric consultant in my expenses. And then generally, I try to look at a little bit of history, but I figure about 5% of them are not going to be billable that month. You could bump it up to 10%, but generally I find about 5% are not billable. So if I caseload of 90, then 85, are not going to be billable that month. Or if you wanted to do, 81, are not going to, or 9 rather, are not going to be billable that month. So that's generally what I do.
Verna, do you use a performer or a formula? How do you go about?
I do. We're going to talk about what a pro forma would look like, and I have a little example to be able to show you, and I can talk through it a little bit more. But certainly, yeah, that's actually an important piece. But just even at a very basic level, to know what caseload you're self-sustaining.
Yeah, and I guess we could just ask, do we currently have caseloads at any of the sites? And if so, what are those caseloads? That might be an easier question.
Hi, this is Tisha. How are you?
Hey.
Great.
Can you guys hear me?
Yes, absolutely.
I was in transition. So luckily for us, we will have 2 brand new behavioral health care managers that are coming on board with the grant July 8th. So our numbers are going to look a little bit different because they are bachelor's level trained. So they're not master's level, so they are not quite as expensive as our master's level trained teams. So, and right now our people are splitting. So our caseload in Batesville runs at around 30, but he does behavioral health care management and he's a behavioral health consultant.
So yeah, the splitting often doesn't necessarily work. I'm wondering, how are you gonna pay for, without the Medicaid reimbursement, what's the business plan to pay for the bachelor's prepared?
Right now the business plan is they are paid for through the SAMHSA grant. And then Medicaid has promised mostly that they will be reimbursing at some point during this grant. So
yeah.
And I mean that's kind of the purpose of the grant.
Yeah. And I think it's important to know, though, like with your current reimbursement rates and knowing that Medicaid is probably going to come in around the Medicare rates, what that actually looks like for your organization. So to take your payer mix And also, you know, once you get reimbursement, I do think it's important to have individuals that can provide all of the treatment choices. And so that generally, you know, oftentimes when you have bachelors prepared, then you wind up having to have others do some of the treatment choices, unless you really train them up. Problem-solving treatment is in scope for them, as is sort of the more formal behavioral activation. So you could actually really train them up on those so that they could do at least some of the
Yes, the plan is to train them in behavioral activation and problem solving. And
yeah.
although they
Yeah,
are
yeah, yeah.
bachelor's level, like one of them is an experienced community health worker who's done a lot of clinical things, and another one she's a social work trained bachelor's level and has quite a bit of experience. So they're not, you know, inexperienced people who haven't worked in
Right,
the
right,
behavioral
right,
health
right.
clinical world.
Yeah, yeah. Okay, awesome. Has anyone else looked at what that might look like? But I think, Tisha, what's really important is you've looked at, hey, it's about 70 patients and we're self-sustaining. That doesn't mean they're going to have a caseload of 70, but you know where you are self-sustaining, and that's a really important piece. So thank you for sharing that.
No problem. And literally just found out what the salary was going to be for these new team members, because as you know, in big organizations, that all kind of goes through the pipeline and we don't know. So now that we know what the salary is going to be, we can do more of the calculations for our new team members.
Yeah. Perfect. Well,
Thank
thank
you.
you. Has anyone else looked at it, or do others have questions around it? It's super important because now that Tisha knows that, then she's going to make sure, and it also tells you when you're self-sustaining. So that's why I always say 30 patients the first month, 60 the second, you know, and 90 the third. So that really 2 or 3 months in, you're self-sustaining. And even if you say, well, we have a grant, we don't need to necessarily do that. You know, we continually find that organizations who do that, and I was just having a conversation last week with the AIM Center and sort of saying the same thing with Anna there, that essentially organizations that do that just seem to be up and running in collaborative care and seem to be humming along, whereas others don't necessarily get the uptake, and just struggle a lot more. So it's really important sort of for multiple reasons. Any other questions about what we've talked about so far? Okay. Let's talk a little bit about some of the codes and what they look like. I wanted to take a minute and just talk about some of the screening codes, because we find out that they are actually not really optimized. And sometimes people say, well, they're not a ton of money, and that's true. They're not a ton of money, but you should bill for them. And for FQHCs, they are not billed above your PPS rate. So for your Medicaid patients, you're not going to get any additional. But for your commercial and for your Medicare patients, you actually will. Your Medicare patients, it's covered in the annual wellness visit, but other than that, you can actually get reimbursed. And so what I oftentimes tell people is just use the codes, so that you can get reimbursed when you're eligible to do it. And so you really want to make sure that you can use it when you're doing some of the screening. So the PHQs, the GADs, you know, sometimes when you do the Columbia scales or suicide screening, there's a whole list of tools that we can share. And the thing is that each of the commercial plans pays for them a little bit differently. And so it's good just to include them on the claims. The bad news is that anyone who's not a prescriber, so your social workers, your care managers, your psychologists, those folks are not able to bill these codes. We're hoping in some advocacy that will change. These are really for prescribers to add on. so that they're able to get paid for some of the screening efforts. And these are some of the tools that are actually included in the guidance, although it really expands beyond this. But generally the codes that, the screening that you would use apply to the tools in collaborative care, your PHQs and your GADs in particular for this. But a lot of times you hear guidance that says you can bill for up to 4 screening codes in a session. The reality is payers don't pay that. They'll generally pay 1. But it does add up. If you have 1,000 patients and you're doing screening, then you want to make sure, that you're getting that in there. The other thing is for Medicare. Oh boy, Patty, you guys are just rock stars. Yes, if you could do that, let's write a paper on it so that you could get the other plans to do it. That's a really important piece, letting all providers build those screening codes. So thank you. Yeah, that would be humongous, and you would be a leader in the field, more so than you are. So the screening codes for Medicare, again, this GO444 code is interesting because it allows you to bill it once a year. It doesn't include in the sort of that annual wellness visit for Medicare, but you do get paid for it. It is helpful to do. And, you should probably try to do it. It's also a quality measure to be able to have a screening rate. Oftentimes practices will say, well, I can't really be bothered, but the reality is any money is good money. And so you may as well try. It also helps you in structured data way around your screening rate. So I would, encourage you to think about optimizing it and doing it. The other screening code that's not on here is the 96161, and that's the code for screening for pediatrics, so newborn babies. That's the code that you would use even though you're screening mom. And that code actually pays a little bit more, and it happens in the pediatric practices. So that's one to really think about. So if you're not optimizing some of these codes or you're not using them, then it might be helpful to think about. And oftentimes when I talk to practices, they'll say, oh, I think we use them, but when you go back and look at, like, are you getting paid for them? And many times there's small fixable things that allow you to then get paid for them. And Patty, it might actually be interesting to look at how many of your practices are billing these codes that are in this project. We've done projects in the past where practices say we bill, and the plans are like, well, that's funny because we don't actually have any claims from you. And oftentimes it's because there might have needed to be a modifier, or sometimes they fall so far down on the claim form that they don't actually get out the door. And so one of the things that you might do, and Patty could maybe be a leader here as well, is actually reconcile that, because it can be real revenue. And Patty, I don't know if you want to add what you've sort of seen on your side around the screening codes or conversations that you guys are having. I love that you're being so progressive.
Well, it's often an oversight for payers, I think, to pay the screens. But honestly, Blue Cross has been supporting integrated behavioral health before I was ever there. But it takes a lot of little computer changes for a payer to pay certain codes. So it takes some active work. But we are moving toward the idea of paying for all clinicians in all settings, because like you said, sometimes the PCPs are limited in which PCPs can be limited, whether nurse practitioners and physicians, as well as the other clinicians. And so I think we're almost there on the screening codes, but it is a challenge for all payers. So I have a sympathy for the others if they haven't figured that out. But
yeah,
I think all payers are really want everyone to do screens because of the value to the overall care of all patients. So and there may be a lot of value-based quality payments that practices can get into also.
Yeah, and I would ask, a lot of times, the screening codes might get denied and practices don't pick it up because the claim got paid. And so they don't actually know that they're not getting paid. So I would encourage you to look at that, to think about it. And also, I've had instances where the screening codes weren't added to the provider profile. And so that actually is helpful as well to say, wait a minute, why aren't we getting paid for some of these? And sometimes it's a really simple fix. So it's something that you could actually do and look at. How much have we got paid? How many times have we billed it? Are we even using these codes? And it's definitely revenue. And there's no point in tossing away revenue. So I want to just stop there for a minute and ask if there's any questions around screening, or when to use the screening, or how that works, or what some of you are doing around screening. How many of you bill for screening?
I was gonna say, that's a great question, Verna, to start with. Is anyone?
Oh, you're talking about.
I'm hearing that we do.
Okay, and do you have any idea, what that looks like, or, if you're getting paid for all of the claims?
Not certain on that.
Yeah. Might be worth, even checking and oftentimes just saying to a payer, how many claims have you received from us? And then looking at how many claims you dropped and sort of seeing where that matches up. And then likely if you're having a problem with one payer, you're having it with others. But the revenue does certainly add up. Yeah. So working on it. Yeah. Oftentimes there's a couple of considerations. One, and do some test claims. Some organizations will say, well, we pay once a year, we pay twice a year, blah, blah, blah. But I would just bill it. Is also to make sure that it's appearing on the claim form. Because sometimes if you have a lot of diagnoses or things going on, it might drop to the bottom and not get out the door. So these are some things to be able to check on. So part of this project is to also think about what you're doing around screening. And particularly if you're adding screening for anxiety as an example, then you want to make sure maybe how can we get some revenue for that.
I know UAMS is working with primary care or with Blue Cross on a value-based kind of project, and part of that is looking at the screenings. And so, like, literally while we were talking about this, I got an email that had some of the data that we've gotten pulled, and I mean, it looks like we are billing 0.1% of, we screen everybody, and
Right.
0.1% is
Yeah.
getting billed, at least through Blue Cross. I think that's who we're looking at right now. So
and you're gonna find
definitely
out
a piece of it.
Yeah, different reasons for that. And that, that revenue actually goes directly, back into the practice. So, no point in giving money away. But I don't think, Tisha, to be honest, that is a very common scenario.
Yeah, looks at in the summary report, there were like 12,000 visits and 43 visits had the screen documented and sent it. Almost everyone that we come into contact always gets screened. So
right. It's a question of how does the code get there? How does it get out the door in a way that's going to get paid? Yeah.
Yeah.
Yeah. Well, I'm glad to see you guys are on that. I mean, honestly, I'd love to have you report that back, because I think people don't realize, the revenue attached to it. Like if you were to have gotten paid, even if it's $4 or $8, for those 43,000 visits, that starts to add up. That starts to be a care manager salary. That starts to be real money coming back into the practice. That could be your yearly bonus, your end of year bonus.
Look at that, Verna. That's awesome. I have a quick question and wondered if you could speak to, we've talked a little bit with the clinics in this model of doing universal screenings, incorporating that as part of a vital sign, kind of like blood pressure. Could you speak to using universal screening as a way to have mental health vital signs?
So some of it also depends on the electronic health record and if you can actually add any of the screenings or something to that section in terms of what it looks like. So that is actually a variable. I definitely like the idea of having the screenings be part of that triage process. I actually think that if those individuals are trained, I think it's incredibly effective. I think not so much if it's not. So like if you're getting less than a 14% positive rate, then you likely need to do some training. But I love the idea of that vital sign and having it be a part of that vital sign. For sure.
Awesome.
Great. So we're all ready to forge forward and build for screening. Okay. So this is a summary. We're going to do just a deep dive, but sometimes it's nice to start out and have it all be in one place. So this first month of collaborative care, and there's a couple of things I think to focus on. For the first month, please note here that outreach and engagement is here. It is not in the subsequent next month code. And so that outreach, I'm trying to call Kim, she's not picking up, I'm leaving a message that actually was intentionally left off of the subsequent codes. And so when you think about what is included in your billable minutes, then that actually is a consideration. You're always going to have entering patients in the registry. There is a lot of discussion around whether or not entering minutes into the EMR is counted. Most err on the fact that it is not, even if your registry is in the EMR. So these are generally the 4 codes that people use most often. We're going to do a little bit of a deep dive into all of them, but this is sort of all of them in one place. The interesting thing to start to think about is at the end of the month, making sure that you're putting people into the right buckets. And oftentimes it's helpful at the end of the first month to say, okay, how many minutes, what's the payer, what code should we use, so that you can talk it through. And then once you do that, then most places are pretty much good to go. So we're going to start with the easier one first. Is this 99484 code. It's kind of like a general behavioral health code. It's not actually considered to be a collaborative care code, and it really requires that 20 minutes a month. And so this code is has to be that 20 minutes a month. This code does not have to be provider billed. This is the only code that does not have to be provider billed. So individuals who are non-prescribers can actually bill this code. A lot of community health workers, outreach, care coordination, sometimes work that medical assistants do. As long as someone has a behavioral health diagnosis, this code is a little bit more of a catch-all. Oftentimes I will call it the code of last resort. And the code of last resort for collaborative care, meaning I didn't meet any of the other minutes. However, I have these 20 minutes so I can bill this code. Oftentimes, if you have services that are not getting billed, you can use this code. So I want to just see if people have questions about this 484. Are people using this code at all? This is really for care coordination, some ongoing monitoring.
Berta, can you give us like an example of what that might look like where we would utilize this code? Because this is one we don't utilize currently.
So if I'm a behavioral health care manager and you were referred to me towards the end of the month, and I had a brief conversation with you and set a goal and then followed up, I brought you to my psychiatric consultant because you've been having a lot of trouble with a medication that your primary care provider started you on. But when I added you to my registry, but when I added all of that up, you were only 21 minutes or 20 minutes. And so that wouldn't be enough to bill a 492 or a 493. So I would use this code. I've known organizations that have had months where they haven't had a psychiatric consultant and couldn't bill the collaborative care codes that then defaulted to bill patients under this code. Was that helpful?
Yes, and I think we've got some questions in the chat from our people.
So 99484 usually for commercial payers. So the commercial payers, except for Anthem, all pay the 99484. It's in the fee schedules. And so yes, you can absolutely do that. So many, all of the blue plans are paying that. All of your commercial plans are paying that. Medicare pays it. Medicare Advantage pays it. So essentially, it's pretty much across your payer mix that you would be able to bill for that 99484 code. And hopefully when Medicaid passes the codes, they will include that code. But as Patty put, then, you know, the blue plan is paying for and recognizing that code. But if you have patients that don't meet the minutes, oftentimes they will fall into this code because you're better to be able to bill them than not. So let's talk about the primary CPT codes for collaborative care. So your 99492 is that initial month, right? Your 70 minutes. And those activities are that initial outreach, there's some assessment. And again, it doesn't have to be a traditional behavioral health assessment. It's just me getting the information that I need to be able to care for someone. So that's 70 minutes that first month. And then subsequently, any other months are the 99493, right? Sometimes people will ask me, well, how long, if somebody drops out of care, how long are they out of care before I can do another 492? And that's 6 months. So if I'm out of care for 6 months, then you can start me all over again. If it's less than 6 months, then you just continue on with those 493s. And that's 60 minutes a month. Notice that outreach is not included here, but all of the other activities, and we'll talk about what all of those are sort of in one list. And then in your add-on codes, so these are the initial 30-minute add-on codes. Most commercial plans will cap them at 2. Medicare caps them at 2. They can't be billed independently. They have to be billed with a 492 or 493. There are some plans that will pay unlimited 99494s, like Aetna is one of them. There are some plans that if you put in more than 2, they'll deny the whole claim. So you want to just watch that. If you have more than 2 494s and you get a claim denied, then that could likely be why. There are some plans like United that will pay them, but you have to appeal it and send them some information. And then they will actually pay the subsequent ones. So this 494, for most general purposes, you're just going to have 2, because that's usually where you land in terms of providing care. Yes, everyone gets the recording and PowerPoints and all of that. So helpful to think about. So remember, these are billed by the providers. And anyone who can do that E&M code, so your primary care providers, your nurse practitioners, all of those folks providing primary care, also specialty care providers can do them. So if I have a GI provider, a cardiologist, some of those women's health, pediatric providers, all of those can actually use these codes. And so one of the things to also think about is you don't have to credential or professionally appoint your behavioral health providers if they're only using these codes, because the bills are going out under the primary care provider and the primary care provider is getting reimbursed. The claims are getting paid. Those are primary care claims. They are not behavioral health claims. And so that's a really important component. And that means you don't actually have to credential in any of the plans, the behavioral health provider. Does it require that the provider attests to the claim? No, it actually does not. So organizations have multiple different kinds of workflows. Some organizations will route the open encounter, and generally the behavioral health clinicians will do one, encounter for the month. They'll change the authorizing provider, route it to the primary care provider, and then oftentimes they'll just sign off on it and out the door it goes. Some organizations will have the care manager put the code in, and it just gets dropped out the door. Very, very few organizations actually have the providers co-sign the chart. And that's predominantly for some workflow information, because, that can really hold up the going out the door, because then they get backed up. The claims don't go out the door. It becomes really provider dependent, and that doesn't work. So oftentimes that workflow is not helpful, and organizations will move from it if they started that way. So hopefully that answered the question.
Thank you.
But
That's so helpful, because I think that could be a logistical issue that they may not know how to, sometimes it could be challenging. How do we gather the minutes, get the claim out the door? And so thank you for explaining that.
Yeah, where it comes up a lot is where organization, mostly the compliance people, and I love compliance people, so I'm not being mean here, is that they'll say, well, the CMS says that providers need to be engaged in care. And so by them co-signing the chart, that actually shows that they're engaged in care. I would argue that doesn't actually show that they're engaged in care. That really what shows that is the referral, right? I talked to the patient, I put the referral in, and I had a conversation with the patient about consent. So right now, and this is sort of going to the question in the chat, CMS still requires that the primary care provider get consent, which really just means that the patient consents to the referral and care. We are hopefully going to get that changed very soon so that it's anyone on the care team can get consent. But essentially, you need that provider referral for the clock to start, and then the provider to document consent. That can be a checkbox, it can be a sentence, it can be whatever that looks like. But that is what is actually required. And by sharing the notes with the PCP, by them getting the psychiatric consultations and reviewing them, by them being copied at the chart at the end of the month, that actually is what most people feel is like sufficient engagement and involvement with the patient's care to meet that CMS requirement for primary care involvement or engagement. So a couple of things to think about. There is a requirement in there that if a patient does want face-to-face and request it, it has to be available. Otherwise, it's understood that these services are telephonic. There is no difference in your ability to do video versus phone versus in person. All of those count towards those monthly minutes. So couple of things to think about. And one of the things to also understand is how to think about coding. So if I get a warm handoff, well, let's actually look at this. So if there's a warm handoff for 17 minutes, I talk to the PCP for 6 minutes, I have an 8-minute psychiatric consultation, and I have 6 follow-up phone calls for a total of 44 minutes. What code are we using here? Anybody want to hazard a guess? So I see something in the chat. Yep, we're going to talk about FQHCs, absolutely. Yes, thank you, Tisha. Yes. So this is a 99492. So it's going to be that initial code we made our 70 minutes to be able to bill that initial monthly code. So now I don't want to make all of your brains hurt. Unfortunately, that's the webinar we're doing today. So there is something called the 1/2+1 rule, and this actually recently has been clarified, and I need to update this. It is for any time a CPT code is used, so not just so not the G codes, which we'll talk about, but for any CPT code. So your 99492, 493, 494. It is called the 1/2+1. And what that means is that if I have a 99492, half of that is 30 minutes. If I have 1 more minute, 31 minutes, I can bill the code for the month. 1/2+1 for a 99492, then I'm at 35 minutes is half plus 1 is 36. If I'm a 99494, then half of that is 15 plus 1 is 16. So I can't 1/2+1 a 492 and then add on a 494 1/2+1. I would have to get the full 99492, and then I could 1/2+1 the 494. And if I had a second 494, I could do the full 492, the full 494, and I could 1/2+1 the last 494. And so I want to stop there and just answer questions about the 1/2+1. It doesn't apply to the 99484, that 20 minutes, and it doesn't apply to any G codes, which we're gonna also talk about. So I want to stop there and just answer questions about the 1/2+1, because a lot of times people think, oh, I have to make that full time, and you do not. Are people using this? Were you familiar with it? Yeah. Yep, same as the psychotherapy codes, and any CPT code actually applies to the 1/2+1 rule, which is why, yeah, 16 minutes as an example, yeah. So it sounds like people are familiar with the 1/2+1 rule. Are you using it? So for your first month, you could essentially 36 minutes. Okay. Yeah, it's helpful, you know, it is helpful. It does allow you to increase the numbers. Okay, so many of you are familiar from the psychotherapy code, so you're familiar with the 1/2+1. There is a little bit of a late addition. To be honest, a lot of people don't use this code. I think for a couple of different reasons. So this is for 30 minutes in a month of care. So if I don't make the minutes for the other code, then I can use this for 30 minutes. most places will meet the extra minute for the 1/2+1 as an example. So very few people actually use this. Okay. So again, the G code sounds like people don't have questions or sort of familiar with that. So maybe this is a good natural place to start after we sort of talked about the codes a little bit. I know that we generally build in a break. Kim, is it all right now? Maybe, Caitlin, we take 10 minutes now?
That sounds like a great place to stop. And you know, we want to make sure we're giving everyone a break because this is technical. There's a lot of information. And so we want to make sure everyone gets a chance to get a drink, go to the bathroom, whatever they need to do, and we'll come back and keep at it.
And you know, I guess just a little disclaimer, like this is hard stuff, like you know, like it's just billing and coding. And so I think, you know, we're just gonna do our best to answer all of the questions and really give you a good solid foundation. And I promise we'll be more interesting in the next webinars because I just know this is like really dry stuff. But really, hopefully thinking through all of your scenarios. And again, you know, you really want to make sure a majority of your patients are being billed. If you find out that more than 10% of your population is not getting billed every month, Houston, you have a problem. It's an engagement problem. It's a carrying over on the registry problem. Whatever it is, might be different reasons, but use that as your benchmark. Maybe it's care manager training, maybe it's something else, but that really, and that means that we're putting it out to get billed, right? And if you then are finding that you're getting denials, then most of the denials in collaborative care are very fixable. We see very, very few denial rates. Very compared to other services, pretty much none. So dual eligibles are those patients who have Medicaid and Medicare, making sure that you're billing the primary first. That's often important. And in most places where you have dual coverage, then Medicare will get paid first and Medicaid will often pay the balance, even if they don't pay the collaborative care codes. And my understanding is that is true for your state as well. And so for your dual eligibles, making sure that you've got a process or something figured out for them, because you're going to have a lot of patients that have both Medicaid and Medicare, and Medicare being their primary. So a couple of considerations to really think about. The rates are going to adjust by region so that if you have multiple sites, then you may have different Medicare rates. You often see that. Remember, if you have a lot of mid-level providers, so nurse practitioners, that particularly for Medicare and some of your commercial patients, they're going to pay less for those collaborative care codes like they do for other E&M codes, that these rates are adjusted yearly. Like last year, the 99493 went down a little bit. That patients can be in multiple initiatives unless you're an FQHC, but chronic care management as an example. So also don't exclude the specialty providers. I mentioned them before. The thing about specialty providers is you might have a higher copay, but you should really think about including them. Same with your medication treatment services or your HIV services. If you get any Ryan White funding or other things, collaborative care does really nicely with those populations. And remember that the referral in the chart is what starts the clock. So I had a practice ask me, well, can we run reports of all the patients on medications? Absolutely. I love that idea. Call them up, have a script, ask them if the medications are working, engage them in care. So, however, the clock doesn't start until the provider puts the referral in. If they put it in same day, I wouldn't worry about it. But if they put it in next day or 2 days, then you really can't technically start the clock until that primary care provider referral is in. So any of the minutes that happened before that wouldn't actually count. So here's where hopefully we'll have lots of animated discussion and we can ask lots of questions. Here's the things that are included in the codes. So your psychiatric consultation, and remember, it's only counted once. So if I talk to my psychiatric consultant for 8 minutes about Caitlin, I count the 8 minutes. They don't count any time, right? It's just that 8 minutes. Discussion, case reviews with primary care. So I can, if I'm a care manager, I can count that time towards my monthly minutes. And if I'm a primary care provider, who knows that? What can I do if I'm a primary care provider? How does that get paid for? We don't count it in the collaborative care minutes. Anybody have any ideas?
Don't they have collaboration codes that they can use?
They could use one of the collaboration codes, or if it's the same day as the visit, they could add it to the time and complexity of their E&M code. So either one. But yeah, you definitely want to try to figure some of that out because that's actually really going to be helpful. The registry management. So if I'm updating my registry, telephone work, right? We've talked about that a lot. Discussions with collaterals. The other day I talked to a husband, right, about how to the PHQ-9, and he was working with his wife and they were putting it on the fridge so that they had it handy. In-person visits, which we'll talk a little bit more, but if I see someone in person, those minutes can count. You have to make sure it's all documented in your EMR. And the thing that you want to make sure that you do is the exact time. So I don't want to say, well, every time I update my registry, I'm going to put 1 minute or 2 minutes, or every time I do an outreach call, it's 1 minute. You really want to look at the exact time. We want to make sure that we're not counting these concrete services. So the food stamps, the housing, the transportation, those are not included in these codes. Fortunately, we have other codes now that we can use around social determinants, but they're not actually included in these codes. Oftentimes that title care manager throws people off and they forget that collaborative care is identification and treatment. And they feel like there's a lot of like these care coordination, you know, social determinant, concrete services kinds of things that can get included. And so remembering that those are actually carved out and we don't bill for those as part of collaborative care. We want to make sure that 90% of the time, so if I work a 40-hour work week, that 90% of my time, right, 32 hours of my time, or I'm not too tired to do the math, 90% of my time is actually billable in that it's attached to a billable episode. And 90% of my episodes are billable. So do people have questions about what's included in time or not included in time, or how to figure that out?
Berna, I have a question. We were just talking about what if a medical provider's seeing a patient and they request the behavioral health consultant either through telehealth or face-to-face come in and be a part of the visit and for a consultation there with the patient. Is that, where exactly would that fall into place? Because we do quite a bit of that, and that's, you can't schedule it, it just happens as it happens, but.
Yeah, I would say it doesn't always need to happen, but yeah, that would actually count towards the monthly minutes. So I would have the provider put the referral in as part of that visit. And then the clock would count the minute I step into the room to start to interact with that patient as part of the warm handoff. That would actually be counted in the collaborative care minutes. And that's often a super helpful way to begin to actually count some of those minutes. So before, you might have had to meet enough minutes to bill a psychotherapy code. You don't have to do that now. Does that make sense, or does that answer the question?
Yes, I just think we identified some stuff we could capture that we weren't.
Yeah. And a lot of times people think, oh, because there's no same day billing, or they think, you know, that it does, you know, they've heard so much about warm handoffs not counting, they forget to count those. You also remember that the provider can then add to the time and complexity for their visit, right? So you could actually wind up billing both of those. The other question that comes up is, what about somebody who's in the hospital? So we know that people who have a cardiac event are way more at risk, right? For readmissions, for depression, anxiety, suicide. And so if somebody has a cardiac event and they're in the hospital, I could actually call them while they're in the hospital, engage them in collaborative care, have some collaborative care minutes. As long as they're not in the hospital for the entire month, I can actually, you know, care for them and do some telephonic work while they're there. And that actually counts towards the billable time as well. Questions about, go ahead.
I was just saying that was very helpful. Thank you.
I would find that many times I see that care managers under document their time. And it really does add up. If you think even about the 1/2+1 rule and the difference between 35 and 36 minutes, like those single minutes do add up. And so you really do want to make sure that you're tracking them. The other question that I get sometimes is about groups. You can't run groups in collaborative care, not because I don't think they wouldn't be helpful, but because CMS has clearly said there's absolutely no way to determine how much time per patient. And since these codes are based on time per patient, then it's a no-go. Questions? Oftentimes, this is where people get stuck or have questions. And remember, documenting in the EMR is considered administrative. So here's where we're going to think a little bit about some of the codes and doing a little bit of a pro forma. So when we think about, I like to divide it up, and this is just quick and dirty to give you a little sense. So your Medicare, your Medicaid, and your commercial. So for Medicare, it's what your Medicare rate is. And then Medicaid for here, it's just going to be your Blue Cross patients. So what your Blue patients would pay. And then your commercial rates, whatever you contract for your commercial rates, whatever percentage of Medicare is what your commercial contracts are going to pay. And you're going to look at that across the 3 codes. And then you're going to have a sense of what your reimbursement is going to be, right? And so let's just say, I'm going to go back to this for a second. So then we know our average reimbursement for each of these. And then we can figure out, or we can ask, what percentage of our patients are in each of these, so that we can figure that out. And then we look at then what our average monthly reimbursement is. And so just for easy math here, we said $150, but for many of you, that would actually be much higher. Probably $180 a month as an example. We're going to take some away. So there's something to think about in terms of copays. And the copays are counted towards your revenue. It depends on how good or not your organization is at collecting copays. Remember, for your commercial plans, if I pay $20, to go see my primary care provider, then I'm going to have a $20 copay for collaborative care. And that's going to be the same for Medicare and for my commercials. That's what it's going to look like. And so it could be that if you're not collecting some of your copays, then that's going to reduce your monthly amount for your Medicare and your commercial patients. It's going to cost you some to do the billing, right? So we actually looked at what it would look like if someone had $150, right, per patient per month, and what that looked like then for one provider who had maybe one patient, who had 50 patients, who had 100 patients, and what the revenue starts to look like. And so I worked with a practice earlier, and they had a caseload of 80 patients, and they had an average revenue each month of $160. So your timing or you're timesing that $160 every month by the number of patients. And if you look at it then, so if I'm taking $160, I erased what their outcome was on my phone. So that's $12,800 a month in that revenue. So we're not going to get paid for all 80 patients, right? Let's just say we get paid for 70, right? And so now we're down a little bit. And then what we want to do is we're going to minus what it costs us. So we have $11,200 a month. We're going to minus what it costs us for our care manager and our psychiatric consultant. And for this happened to be about $3,000 a month, a little bit over. And so they had a revenue left over of about $8,000 a month. And so that's generally how organizations will look at it. And so it's super helpful for you to know what your average monthly revenue is. And you can do it two ways. You can say, here's our average monthly revenue. We have a third Medicare, a third Medicaid, and a third commercial. I'm going to put all of those together. I'm going to average it out. And that's my average monthly payment. What I like to do is say, okay, I have 30% Medicare, and that's going to pay $180 a month, 30% Medicaid, and that's going to pay an average of $170 a month. And I have 30% commercial, and that's going to pay an average of $200 a month. And so then I multiply that out. So if I have a caseload of 90, this is just quick and dirty, then 30 of my patients would be Medicaid, 30 would be Medicare, and 30 would be commercial, and I figure it out that way. And so I think that's actually a little bit cleaner and a little bit more accurate. But I want to stop there and just answer any questions.
I have to say, Verna, looking at this is fantastic. And we could potentially develop this into a form and make sure we get this out to.
I have it. I can actually share a pro forma with you that you can fill out. It really depends on how complicated you want to get or not. We've actually looked at the number of patients each month that might be a 492 versus a 493 and figured it out that way. Like if you really want to complicate your life for a pro forma, or you can do something a little bit, quicker and dirtier. So it depends. I actually have both versions so that you can see in the average number of, contacts per month and how many 494s in that. But it is important to really understand, and I can't stress this enough, like grant funding is wonderful. I love grant funding. I spend a good chunk of my life writing grants. However, what I find is that organizations don't pay enough attention to the finances in the pro forma if they get grant funding. And then the thing about it is that if I know from the beginning that I need to have 70 patients, let's just take Tisha's example, then I need to have 70 patients in order to be self-sustaining, and I have an idea of what my pro forma looks like, then I'm going to design my services and say, wait a minute, you know what, we really need to focus on really outreaching to our Medicare or our commercial patients, because that actually is going to be really helpful in terms of driving the revenue. Or we're going to do this in the pediatric practice, it's going to be a little bit lower. And so I really need to understand what the new number looks like so that I know where self-sustaining is, because that's going to drive how you set up your services. It's going to drive some of your workflows. It's going to drive the information to your care manager. Oftentimes, if you start someone and they're kind of going along and they've got 15 patients and 20 patients, and you're like, oh, you know, we're doing good, we're growing, but you really know that you need 70 patients. People get really comfortable at 20 patients. And so then when you start telling them, you know, 90 patients or 80 patients, they're not as in love with that idea, and it takes a longer time to ramp them versus if you tell them what the expectations are earlier on, and they really learn how to manage that caseload.
I love that. And so my takeaway is, because we know we have the clinics participating in this project, one of the things you're recommending is we really need to try to, as quickly as we can, after we feel comfortable, we're trained, we have staff hired, we are talking about codes, to try to ramp up to 90 patients so that we are sustainable.
Yes, I get calls from practices all around the country. I was actually gonna share something with you if I can find it here quickly, but I get calls from all around the country all the time, and they say, we had a grant, and the grant is ending, and we love our care manager. We love them. However, you know, we don't know, we've not billed, we don't know what's sustainable, and now we're kind of in a mess, right? And so that actually happens a lot, and it really is problematic. And I really encourage you to try to look at that now. And the other thing is, and here's what I like to do also, is that, you know, let's say I'm getting grant funding and it's paying for a care manager, and I figure out that at 70 patients, I'm self-sustaining. Well, if I get that care manager to a full caseload and we're self-sustaining, I can roll that grant funding over to support a new care manager. And 3 months later, I can have them be self-sustaining. And I can keep rolling that grant money so that that grant money actually supports hiring 6 care managers instead of just 1 or 2. And that really is oftentimes a really helpful way to sort of think about some of that grant funding, because that actually will really help you really grow your services and help support that in a way that's very different. And a lot of times we don't think about doing it that way. So I really encourage you to think about it so that you can look at it and, you know, get a sense of how that looks. Does that sort of make sense to people? And maybe you didn't even think about doing that.
Absolutely. And there's a comment from Tisha.
Yeah, I'm just saying that's how at least I asked that it be written in for UAMS, was that they're rolling. So in order to support all of our clinics, the ones that start at the beginning are going to have to be sustainable before we start rolling into other clinics. So
yeah.
And I've already told them I will not be hiring a bunch of people that I can't keep at the end of the grant.
It's heartbreaking how often that actually happens. It happens a lot, and I get calls from people and they're not thinking about what this looks like, you know, right from the beginning. And it takes time to set up billing, and it takes time to set up some of these other pieces. And so then what happens is that it's by the time they are like, oh, we really have to build this out. Oh, we have to figure out the billing. We have to understand, we have to know what our, care managers are doing. Then that actually, oftentimes is really problematic. So I really encourage you to do it now. Okay.
I'm just curious, from a programmatic and grant perspective, I know we've just heard from UAMS. I don't know if any of the other organizations participating in the grant have thoughts on this, thoughts that we start to conceptualize how we can set up billing, hire staffing, and start to have the initial cohorts of the BHCM sustainable before moving to a second site. And if not, that's okay. We can keep talking about this in our individual calls, but just wanted to get initial reactions.
So we know some FQHCs here that we're billing the 511 and the 512 codes. The G511 can actually now be billed multiple times. CMS recently updated the MLN, the Learning Network Guide for FQHCs. So if you haven't seen that and you're an FQHC, then I can share it. Kim, just let me know if you guys don't have it and I can attach it back. We want to make sure too that oftentimes they actually will require the 60 minutes. That's the big problem with the collaborative care codes and the FQHCs, is that there is no flexibility. You have to get that 60 minutes. And that actually is really difficult for a lot. So that billing the G511 multiple times sometimes is an option. So most Medicare Advantage plans pay these codes. Many of them will still limit the 2494. Oftentimes they're time-based. It is hard for FQHCs because of the different rates and the different codes, like you're using CPT for your commercial codes. And so you really want to start to pay attention to that. Your commercial rates are going to be all over the map. They're going to follow your commercial contracts, but to be honest, the payers are really varied in how they reimburse and what they reimburse. So I am not a fan of actually billing the individual visits. I think it's confusing for the care managers. I understand that if Medicaid is not paying the codes and you have patients that aren't billable other ways under the collaborative care codes, that you need to bill the individual psychotherapy rates for those contacts. So I get that. I think if there's any way to not do that, I would do it. However, if you are doing it, then you need to remember that those minutes don't count towards the collaborative care minutes. So anything that you're billing under a psychotherapy code really needs to stay separate or is separate. And you may need to think about it by staff person, or by payer. So for example, I've had a staff person that predominantly did Medicare, and so they were using just the collaborative care codes, and so really thinking about what that sort of looks like across the board. I also watch because if people are doing too many psychotherapy codes each month, they're probably drifting a bit from the model, but that's a little bit hard to do if you need to do those to bill. The one thing that I will say is that you really want to try to differentiate the individual visit codes that you're doing. So you need to be able to meet the criteria for the CPT code, but you also want to be consistent with collaborative care. So I really give organizations a 4-part template. Why are we talking to someone? Patient here for ongoing care for major depressive disorder. Patient had an initial PHQ of 22, PHQ today is 16. Sleeping, concentrating, continue to be a 3. Moving slowly, continues to be a 2. So I'm doing an assessment of my symptoms. What clinical intervention did I provide? Use behavioral activation to do X, motivational interviewing, patient is in X stage, reframed X cognition using CBT. And then what is my progress towards some of my goals? Set a goal, we'll follow up in 2 days, so that it's a very specific, concise note. And I always tell clinicians who are doing collaborative care and billing those psychotherapy codes, if you find yourself talking about something besides symptoms, give yourself a check, because you're probably moved off point. You're not just doing behavioral health as usual and billing the psychotherapy codes, and then someone else is doing a PHQ or GAD over here. You're really using that to be the foundation of the sessions, and you're having a symptom-based conversation so that it's consistent with what would be happening or what should be happening in collaborative care as a treatment choice of talk treatment. So oftentimes I see, well, we're doing collaborative care. Okay, well, we're doing PHQs and GADs and we're tracking the scores. But when I look at the notes that the providers are doing here, they're really just traditional behavioral health notes. And so it's oftentimes really confusing and hard to do. But if you have to do it to be able to make some of it self-sustaining, then I sort of get it. We talked a bit about the 494. If you're getting too many of them, when I was talking to someone the other day, they had a lot of 494s. They had really drifted into doing more traditional services. So you're going to have some that are going to be more than 2. But you definitely want to try to watch that. I really look at it as a flag, like an indicator, to really let me know whether or not somebody, and you will see, so patients at risk for suicide, patients that are initially in care, might go a little bit over that, but you definitely want to watch it. And in general, you want to think about that group. Have you worked with groups that do both PCBH and CoCM and have the care managers build the collaborative care codes? Not exactly what Laura Sadari does. And actually, I think your collaborative care is an evidence-based model. And if you're going to do collaborative care, then you need to do it. And if you can build the collaborative care codes, then you should just build them sort of in their entirety and do collaborative care, and you can be self-sustaining. I generally find that in theory, it seems to be a good idea to have someone do like talk treatment and bill for that, and then have someone else do other collaborative care components or other treatment choices. And here's what I find almost all the time is that the collaborative care uptake doesn't seem to be as high. That if you really look at the charts, you're not actually seeing collaborative care, you're sort of seeing 2 different tracks. And that happens pretty consistently. And so you really wind up drifting from the model, and it tends to not necessarily be optimal. And so there might be a portion of your patients that you say, okay, this might be how we do it. But if you're able to build collaborative care codes across that particular payer mix, then I would just do it. Providers, it's very hard to tell a clinician, listen, do this for most of your patients, but if you get a collaborative care patient, you do your session this way. Like they tend to not do it. And so am I going to use tools and track outcomes over here and be very symptom focused, but I'm going to do something different over here? Like it always seems like a good idea in theory, and then it never seems to play out well on the ground. So definitely just sort of putting that out there a little bit.
That is so helpful, Verna. I think that all of the programs in this particular grant all have BHCs functioning in a PCBH model. And so now they're incorporating this CoCM model. So I think it's wonderful for us to all hear from you that it's really challenging to have the BHC then crossover and function as a BHCM.
It almost never works. It seems like it would work, but really it never does. And there's a lot of places that actually won't even do implementations or support if that's going to be the model. And that's it really, if you're going to do collaborative care, then have someone do collaborative care. It's a job, it's self-sustaining, you have grant money, have them do collaborative care, follow the model, be able to do all of the treatment choices, really get the providers to understand what it is and have it be, because not everybody is going to be in collaborative care, right? You're going to have a population of people that are going to get other treatments, other evidence-based treatments, your early childhood, your not measurement-based diagnoses, they're going to get care. Like there's plenty of services for those folks to provide. And there's plenty of services for someone to do collaborative care to provide, right? And so I always think of it like, let's just take EMDR, for trauma. We're not going to have somebody getting EMDR and then doing this also, right? Somebody's going to do EMDR. That's what they're going to do. They're going to use that evidence-based track practice to treat sort of the trauma. And this is the same, like we're going to use collaborative care, it's evidence-based, we're going to use it to be able to provide that model, and then we're going to have, do that. And that is actually the best way to do it. And it's also, to be honest, like at the end of the day, clinicians don't like it. They don't like to do both. They don't like to be split. And also then a lot of times the collaborative care enrollment is very low, because if I have to put someone on a registry, I have to be accountable for the outcome, I have to do the tools, I'm going to keep people over here and not put them in collaborative care. And you tend to see that a lot. And so I will also just really advocate for having someone do that together. So I moved past this code because we had talked about it a little bit before. So did you have a question? I got something in the chat to move back. Was this the slide you were talking about? Or did we have questions on the 99484?
You're saying yes.
Okay. Yeah. Okay, yeah, so this is, that 484, which is our other behavioral health codes. Our FQHC providers unfortunately can't do it for Medicare. They can, however, for your commercial plans. And it's oftentimes the code of last resort. And again, Anthem does not pay this code. So a couple of thoughts about copays. So you're going to have a lot of patients that have high deductibles, like some of those union plans, the local plans. And the reality is they're going to have high deductibles no matter what services they get. So that just kind of is what it is. But do keep that in mind, like when you're coming around to January, as an example, when things get reset. So think about specialty providers. The thing is, like women's health, cardiology, you can enroll those patients in collaborative care, absolutely. They may get a specialty copay. So the copay might be a little bit higher. If I pay $50 to see my cardiologist, then it's going to be $50 for a month of collaborative care. So just keep that in mind. If you're in a system where there's specialty providers and primary care, then maybe the primary care provider does the referral, but just sort of keep that in mind. And remember that the copay is the same as it would be for primary care. It doesn't follow behavioral health, and it is going to vary a little bit with plans. Like as an example, some plans will charge, if I See, Tisha, and I do a 99493 and two 99494s. Some plans will charge a copay for all three of those codes, and others will just charge it for the 492 or 493.
Okay.
So that's an important thing to remember.
I'm
Go
curious.
ahead.
Do you ever see the copay as a barrier to patients participating in CoCM?
Yeah, it's it's certainly a barrier. We do a ton of advocacy around that. The other thing that I've learned is I don't actually talk to patients about their copay right away. Because if you do, then they're like, nope, I'm out, right? But I say, I'm wondering what's something you could do today or tomorrow that, you would be less anxious. You felt anxious for like, it's been a really long time. And we set a goal and we talk about it. Maybe we problem solve around some medication. It's really hard to take medication every day. Yeah, it is. And I do really well during the week, but then on the weekend, it all goes to heck because I don't have a schedule. Well, what's something you do every weekend? And like we problem solve. And I'd say, gosh, I'd love to give you a call on Monday. Like, how'd that go? See how it went for you. And I just want to let you know, like us working together is part of your insurance benefit, and it would cost what you paid to see your primary care provider today, and it's for a month, and here's the kind of thing. So I talk to them after I've like, what's the worst that happens is I've set a goal or done some problem solving with them, right? But most of the time, then they kind of get what it is, and then they can make a decision about whether or not they want to engage and pay the copay. So I will do it afterwards. I don't talk to them about the copay in the beginning.
That's really helpful. Thank you.
So some of the real common pitfalls, there are some really big reasons that practices are not self-sustaining. And I have to tell you, most of them are not related to reimbursement or rates. Predominantly. One of the biggest things is that people get stuck in that land of perpetual launch and they don't get enough patients. If you don't have enough patients, you're not going to generate enough revenue. Like that's any service line. It's not just collaborative care. But for some reason, I talked to a practice the other day and the primary care provider was telling me, I love collaborative care. You were right. I love collaborative care. It is so helpful. I put patients in it. It's amazing. I love my care manager. And I said, gosh, I would love to be recording this conversation. Like, how many people do you have in collaborative care? And he literally looked at me and said 12. And I said, well, that's wonderful, but that isn't going to keep you sustaining. Like, you're not going to be able to do this. Like, you're losing money. You're paying your care manager. And so we had to really talk about it. Like, if you want to make that decision, fine. But otherwise, you really need to think about ramping it up, and you have the patients, right? They're there. No focus or dedicated staffing. If you split it and you say you're going to do your job, and now for these patients with depression and anxiety, you're going to do collaborative care, that actually doesn't work. You don't get the buy-in. It's not sustainable. They can't really have the caseload of collaborative care. So them as a provider might be sustainable, but collaborative care as a service line winds up not being self-sustaining. And so really just thinking about what that looks like. And the claim forms are incorrect. Oftentimes that's a problem. And it's not actually that you're really getting denials or not getting paid. It's that they're not going out the door right. 494s are getting submitted separately. They're going out under the behavioral health provider, like all kinds of things like that often impact. And so generally it has nothing to do with the reimbursement. It's more about some of these, it's either volume or it's the caseloads. I put in here just a summary of the depression care screening just to kind of bring us back in terms of being able, to optimize some of that. And then I wanted to stop there and really just answer questions that you have around billing and coding and being self-sustaining. Like, I know this is, it was 2 hours of like not super exciting content. Most of us are, you know, behavioral health clinicians, and this doesn't exactly get our juices flowing. But it really is important to understand the business line. Like Tisha's right on. I know how many patients I'm self-sustaining. I have to get them there. This is what it looks like, rolling the grant dollars to continue to support hiring multiple care managers. Really, you know, thinking about a pro forma, understanding what's billing, you know, what's billable and not, and the codes. So I'm gonna stop talking there and, you know, just answer any questions. And I am absolutely glad to talk to any of you at the end of a month and go through patients and say who goes into what bucket. Generally, when a care manager does that once, they're like, oh, I get this. You know, what payer, what code, and we sort of talk it through. Also glad to do pro formas so that you can really roll your grant dollars and optimize them like Tisha's doing, so that she can get 8 care managers instead of 2 that were put in a grant budget. That's going to be tremendously helpful because she has thousands of patients in her system and she could support that. And so, you know, we're glad to help you figure some of those things out. Everybody's just completely overwhelmed. Probably like, oh.
It's a different brain.
It is a
Different part of your
different
brain that you use.
Yeah, much different part of the brain. But again, I'm just gonna say it again. I've even seen this with SAMHSA grants, with other grants. You know, a lot of times people say, okay, well, the grant ends in 6 months. We got to figure this out. And it takes 6 months to load the codes into your EMR and attach the charges to it. It takes people time to pull out the contracts. It takes, and, you know, to drop claims. It takes time to put some of those systems in place. And so if you're not thinking about it now, and setting that up now, so you're billing, even if you're not dropping the claims to straight Medicaid, you're tracking them. That's going to be incredibly helpful going forward because we can send them a bill. But I also think it's important to then help you design your business line, and you're ironing out all the kinks. Your billing people know how to bill it for your Medicare and your commercial, and you've really got a good groove.
You know, one of the things I'm loving this as you're talking about it that could be really helpful is, of course, the Medicaid codes are not currently turned on, so they're not getting billed. However, if we were able to track each visit that was Medicaid, we could then put together a report to show them this is how many Medicaid visits would have happened with this specific patient population in this time frame. And then they start to get an idea of what this could look like.
I just did that for Mercy in Arkansas, and I tallied that up and sent it. And you're absolutely right, because then they can say, oh, this is what the uptake is going to look like. This is what the reimbursement is going to look like. Yeah, you're spot on. And awesome. I can tell you a story about what happened in New York. So New York wanted to be really kind to people. And they decided to put in place a T code so that if you didn't meet the amount of time for a collaborative care code, you could use this code. And so what happened is everybody used that code, and everybody said, oh, we're getting a fixed rate, so we're not going to put the 99494s. We're not going to do any of that. And then what happened is when New York went to CMS to get increased rates, they said, well, you're not even using the 99494, so why are you even coming back to us for increased rates? Or people aren't even. And so because people weren't actually coding for what they were doing and didn't have it in a way that they could report the services to Medicaid, what they were actually providing. And so New York really had a very hard time and didn't get what they wanted or needed in terms of a rate increase, because people hadn't been really doing the billing and coding accurately, even if they weren't getting reimbursed for it. And so I strongly encourage you to be able to do that, because if you look and you say, most of our patients get 2 494s, then you want to make sure that Medicaid is paying for 2 or 3 494s and that the reimbursement is good, right? You want to, and you know your population, and then that can help inform your advocacy and help inform some of the decisions that they make.
Absolutely. Thank you for sharing that story. And hopefully we'll be learning from New York and we'll be able to have an accurate report so that, because you're exactly right, when we're asking, could you please turn the codes on, and not just turn the codes on, but we'd like them to be at 120% of, excuse me, the reimbursement, we have to really show the need and why it's absolutely necessary. And so that's wonderful guidance.
Thing there for your FQHCs is you don't want them to turn the codes on for Medicaid for the FQHCs and use the G codes. You want them to use the CPT codes. And if you could actually show using the CPT codes or track how many minutes the average patient was, then you can say, listen, we would have all this uncompensated care, so you can't do this for the FQHCs. It would be crippling.
Okay, no, that's really helpful, because we have 2 large FQHC systems that are participating in this project. So
yeah, and that's really been a problem in other places in the country. They haven't been able to make it sustainable because that 60 minutes is a killer. And if you think about it, if I engage someone the last week of the month, which happens a lot, it's very hard for me to make that 60 minutes. And then at the end of care, when I'm doing symptom monitoring and phasing someone down, I may not make the 60 minutes. And so you have people at the beginning of care at the end of the month, and for their last month or 2 of care, that all becomes uncompensated care.
Oof.
Yeah. And if you think about the treatment choice of symptom monitoring, the very nature of that is to talk to someone twice a month and, you know, monitor those symptoms. Well, that's going to be very hard to make 60 minutes a month, right? And so you lose all of the people in that treatment choice, which entirely defeats a big purpose of collaborative care.
Absolutely.
Any questions? I know this was a lot, and oftentimes it's hard, like then when you do it, you have questions, but I'm glad to answer any questions about this.
Verna, thank you. We also want to just remind everyone, we do have monthly calls. And so if you can think of questions that come up, please write them down and bring them to our time together. And we would love to try to answer them. If we cannot answer them, we will seek out the advice of Verna and other people that are resources and get you the answers.
And again, I promise we'll have some more exciting content next time. This is, but I think this is really important stuff. And, you know, feel free to come back and ask questions or get help with pro formas.
Before we end, I just wanted to mention that we do have a survey that I put in the chat. So don't run away yet before you do that survey. And if there's other people on the call with you and you guys are just listening on one device, if you'll forward that to them, that would be very helpful, because we're tracking how everyone's responses to the training, their comfortability with the model, and the care team roles and all of that. So if you guys could make sure you do that, that'd be great. Kim, were you talking about a minute ago the CoCM stakeholder meeting, or were you mentioning our office hours?
Both. We do the monthly or the bi-monthly individual calls, and then we'll be offering office hours as well.
Okay, I just want to make, because I was going to look for my to get the link for that, and I was not concentrating. But I just wanted to mention that we will be starting the office hours in July. And just watch for invite. That's for anyone. And if, like Kim said, if you don't have something answered within our calls, you're welcome to join those the third Friday of the month. So just watch for that invite. And then finally, we'll have our last training of this series on July 24th. That's going to be the same time frame, I believe. Let's see here. That one I have from 2 to 5. And that one should be about 3 hours. That should stick to the 3-hour mark. But I will be sending out invites for that as well. You're welcome to forward those invites to whoever you think is important to join us. So just wanted to remind
And
everyone.
yeah, Tisha, it is different than the one that's on the Ames website. I actually worked with the Ames Center to design that one quite a few years ago. And we've actually learned a lot about pro forma since then. And there's some new things, and we've learned about how to balance caseload. So it does look a little bit different. Not that that one doesn't get the job done, but.
Awesome. Okay, well, we appreciate everyone being here with us, hanging in there. We know billing and coding can get really complex. Stretching our brain, getting to use different muscles today. And Verna, it's always a pleasure to see you. I continually learn so much every time I listen to you, and just want to say thank you for being here.
All of you.
We look forward to seeing you in July.
Great. Thank you, everyone. Have a wonderful day.
Thanks so much. Bye-bye.
Bye.